My name is Tobias Nordström. I'm a clinical urologist at Danderyds Hospital, Karolinska Institutet, and also the principal investigator of the Stockholm 3 MRI trial. The Stockholm 3 trial is a screen by invitation diagnostic trial where we have combined a paired and randomized design. 12,750 men from Stockholm have participated, and they have given blood for the analysis of two blood tests, the PSA and the Stockholm 3 test, which includes both clinical parameters, protein measurements, and a SNP-based genetic score. Men with an elevated blood test, PSA or the Stockholm 3 test, have been randomized to a standard biopsy or an MRI strategy where we've been using 1.5 STHLM3MRI and targeted plus systematic biopsies in MRI positive men. And we find that MRI is non-inferior for detection of significant prostate cancer. And at the same time, the MRI targeted strategy is associated with substantially less over-detection of Gleason score 6 tumors. This addresses the main obstacle before thinking about implementing screening. We also find that the Stockholm 3 test can inform risk stratification before any decision to perform MRI or targeted biopsies. And the Stockholm 3 test can decrease the need of MRI with approximately a third and further decrease the need of biopsies or the detection of insignificant cancers. Yes, in the Stockholm 3 MRI trial, 12,750 men living in Stockholm chose to participate out of the 49,000 invited. That's a participation rate of about 26%. That's actually what we thought it would be when we did the power calculation, and I think it's an adequate participation rate. It's slightly lower than some trials that have been done in the past with lower contamination of PSA testing. The situation in Stockholm is that more than half of men in this age group have been PSA tested. So I think that the 26% participation rate is actually quite adequate. When we designed this trial, we sought to assess diagnostic tools for prostate cancer screening. That means that the biopsy indication and how we select men for biopsy was sort of in our core interest, meaning that we assessed both a blood marker test and MRI. At the same time, we have an excellent infrastructure for studies that we have developed in Stockholm for the last decade. That means that we can also assess how the biopsies are performed within the structure of the same trial. So I think we just took the opportunity of assessing both how the biopsies should be performed when we had the chance. The results from this trial mainly confirms what's written in EAU Guidelines. We have the same age span for our participants. We also confirm that MRI targeted biopsy are reasonable to recommend. We also find that it's reasonable to combine both systematic and targeted biopsies when doing an MRI targeted biopsy strategy. Further, we see that additional risk stratification tools such as the Stockholm 3 test provide important contributions before doing an MRI targeted biopsy. So this as a whole confirms what's already in the guidelines. On the same time, it's important to understand that this is a screening cohort. So what we're assessing is a cohort of men that are invited for screening which is quite different from the clinical cohorts that are assessed in our daily clinical practices today, or in EAU guideline, and also in the previous trials, such as the precision trial, which have been known for some years now. Maybe I should just expand a few sentences on the differences between a screening cohort and a clinical cohort. So when we invite men from home, the risk distribution is somewhat lower than in the men that we see in our daily practices. That means that it's a greater challenge for MRI to perform in a screening cohort. Followingly, we see that MRI performs non-inferior for detection of significant cancer, but we don't find that it's superior for detection of significant cancer, which have been seen in many of the previous trials. Nonetheless, we also find that the MRI targeted strategy is associated with substantial less over-detection of insignificant prostate cancer. And this is an important finding, while the levels of over-detection is one of the main obstacles before thinking about implementing prostate cancer screening. The Stockholm 3 test, as it was developed, included a measurement of prostate volume. However, when we do it in this context with MRI, we have chose not to include prostate volume in the diagnostic workflow at all. If we include it, the results will be even stronger. However, it's hard to include from a pragmatic point of view. So for this trial, prostate volume is not a part of the Stockholm 3 test.